Welcome to the Jared Paul Pod.
What? What do we do? This is like our 60th podcast.
I don't
We
even
can't
know how
pronounce
to
it.
start.
What is it?
Welcome to, I think it's the Jerry Powell podcast.
Jerry? Did you say Jerry Bow?
Jerry Bowels, the Bowels of Geriatrics podcast. The Jerry Powell podcast.
Jerry Pell podcast. Oh,
You've
cool.
heard of that before.
I've heard of
This
that.
is your audit. This is Eric Wadera.
This is Alex Smith.
And Alex, I see somebody else in the room.
We have somebody else in the room, and our audience may be able to see it too because we are, for the first time, broadcasting on YouTube as well. This is Wendy Anderson, who is here at UCSF. She's in the Division of Palliative Medicine. She's an expert in communication, is going to talk to us about teaching communication, right?
Teaching communication.
Welcome to the Jerry Pell podcast, Wendy.
So thrilled to be here.
Maybe you can teach me how to start one of these podcasts.
No, you guys are
Is
not.
that what we're going to be talking
no,
about?
you guys are totally click and clack.
So, Wendy, do you have a song for Alex to start us off with?
I do. I don't remember the name of it, but it is in a movie that my kids watch a lot.
Descendants 2?
That's it.
And why do your kids like this movie? What's the deal?
Well, that's a good question. And having little kids, I spend a lot of time like listening to music in the car with them because that's what they like to do.
Right.
And actually, this song, when I listened to the words and looked up an acoustic version, I feel like it's actually a lot about communication training and palliative care. And that it's so much about relationships, and that so much of change starts with just one relationship between one person and another.
That's
so
great.
I actually felt like it's a pretty good fit.
Okay. We gotta be bold, gotta be brave, you gotta be free. Making that change, you gotta believe. Oops. Hold on. We're gonna do that again.
This is video. We can't edit this out.
Yeah, I not only messed up, I forgot to hit the scroll button on my phone. So we'll try that again. That didn't happen. Hello? Hello. You gotta be bold, we gotta be brave, we gotta be free. We gotta get loud, making that change, you gotta believe. We'll look deep inside, and we'll rise up and shine. We can be bold, we can be brave, let everyone see. It starts with you and me, whoa, whoa, hey, hey. It starts with you and me, whoa, hey, hey. Starts with you and me. Something like that.
Amazing.
Now, is this a movie I need to watch? Like, I do have a young kid at home.
Well, I have a feeling that it may be more for girls, but I don't know.
Oh, we'll see.
We can see. I actually like it quite a lot.
Yeah.
Okay.
It's it's very positive, very uplifting.
Yeah.
Yeah. A little bit of Disney theme-ish in there. Maybe we should start with and how do we bridge from Disney to communication skills training? I'm gonna let Eric take that one.
Okay. Communications. So, maybe you can just give us a little background, Wendy. How did you get interested in communication as something that we should teach?
Yeah, sure. So it was when I was in residency at Duke. And when I was in residency at Duke, which was a long time ago now, evidence-based medicine was like the hot new thing.
I've heard of that.
Exactly. And
it was hot and new at one point.
It was hot and new, and I was in residency. So also it was at Duke, and so much was about cardiology, and so there was every single trial that was like, you know, what dose of beta blocker should you give, and which between these different ACE inhibitors should you give, and that kind of thing. And I also had come from a background training in hospice, and that was kind of what brought me into palliative care from San Diego Hospice. And so then I landed in the ICUs at Duke and had some really challenging interactions with families who I thought were just making all the wrong decisions for their patients. And so James Tulsky was my mentor. And,
heard of him.
Yep.
Heard of him.
Yep.
Mm-hmm.
And so he just had these kind of, you know, straightforward things like empathy that really seemed to turn everything around for me, and in those difficult communications. And then at the same time, I was really struck that this thing that seemed like it was so important, that there wasn't the same evidence base that there was, and there weren't proof from interventions the same way that we had them for cardiac disease.
Great. And I guess taking a step forward, do we have that proof now?
I think we have more. We have a lot more.
Oh, you set off the phaser.
I did set off the phaser. So what are you doing now in that regard?
So there's a couple main projects that I'm working on. So one is the director of the Vitaltalk Bay Area Hub. And so it's one of the first hubs for the Vitaltalk organization, which is a nonprofit that teaches communication about serious illness and also trains faculty. And then another project that I've worked on for a long time is called IMPACT-ICU, which is a program that trains bedside nurses in the intensive care unit to work really closely with physicians and other clinicians and families around discussions of prognosis and goals of care.
So let's get into this a little bit more in terms of some specifics around, like, we're teaching communication skills, and mostly, should we focus on in ICU settings or in sort of general?
Everywhere.
Everywhere, okay.
We need to focus everywhere that clinicians are seeing seriously ill patients.
Everywhere. And when we're talking about clinicians, we're talking about who?
I think that's another big question, right? That really most of the data is interventions focused on physicians. And interestingly, Betty Farrell was talking about a review they did before putting together a communication intervention for nurses, a communication curriculum. And what she found, it was like the vast majority of evidence was around, or guidance was initially around breaking bad news, and then physicians. And so I think that that's a big piece that we need to be expanding, which we already have a lot of great guidance about communication across all different domains of palliative care. And I think we're also learning about how can we apply these proven methods for teaching communication skills to other disciplines.
So so you mentioned Vitaltalk. Do you want to just give our audience like a brief descriptor of what Vitaltalk is?
Yeah, sure. So it's a nonprofit. It was founded initially by the investigators that created OncoTalk, which was teaching communication skills to oncology fellows, and they started to envision it like a social change model. And so realized that, originally OncoTalk was funded by national grants, federal grants, and they just realized that we're not gonna make the kind of change that they talk about in Descendants 2.
There you go, there's the link.
Unless we really
well
think
done,
about
well played.
Unless we really think about this is a social change movement. And so they founded a nonprofit, and a lot of the work that we're focused on in Vitaltalk now is all about dissemination. And
there's like multiple, there's Vitaltalk, there's Renal Talk, there's Geriatrics,
OncoTalk.
We're gonna start podcasty talk, help with me.
We need to get that pronunciation right.
So, and when we're talking about evidence-based, so I'm gonna take it a step back, because earlier I was talking with Alex. We were going back to a JAMA article that was published in 2013. I think looking at like Vitaltalk, OncoTalk, and I asked Alex, "Hey, do you remember that we did a GeriPal post on this?" He's all, "No." Turns out Alex did a GeriPal post on the article.
I
that
wrote
came
a
out.
whole post about it and forgot about it completely. Yes.
JAMA in 2013, a study looking at Vitaltalk and whether or not it improved, I think, quality of life, communication, other secondary outcomes. I think depression
among patients,
and it was a largely negative study.
Largely negative in terms of patient-related quality of communication.
See, it's all coming back.
It's coming back now. I can reread it. But depressive symptoms increased among patients randomized to the intervention arm, interns and I think nurse practitioner students who were trained in this. I forget, it was like a 4-day intensive communication seminar. Yeah.
It was residents and advanced practice nurses, right?
Yeah, that's
I think you
right.
just said that.
That's right.
Yeah. So, really important question, and I think that what's so challenging about this area of, thinking about communication skills training is the outcome assessment and the evaluation of it. And
Right.
so I think the thing that's really important to remember about that study is that the clinicians learned. So they did acquire new communication behaviors, such as responding to emotional opportunities with empathy, and there's a lot of evidence showing that those type of communication behaviors are associated with better patient outcomes. I think the challenge is that we often think about communication skills training in a vacuum. So we send people off to do like a one-day course, and then we send them back to their institution and they have no support, and their institution is still the same, and they're the only one at that institution that was trained. And so I think that there's this big leap going from training one individual clinician in communication skills to really a multi-component intervention that's going to need to include training other people, systems change.
Mm-hmm.
So I think the serious illness care program is a really wonderful example of that, where they include prompts of who should you talk to about this, and they have a checklist or conversation guide about topics to discuss, and then they have ways to document in the EMR, and there's audit and feedback, and so you need all of that.
And we're serious illness communication guide, just to review briefly.
Yes.
What is this thing? This is out of Boston.
Yep.
This is like Atul
Yep.
Gawande's Ariadne Labs, and it's led
Exactly.
primarily by Susan Block and Rochelle Bernacki
Right.
and
Exactly.
others. And it's a sort of it's not a checklist. They like to say it's a guide. It's like a toolkit.
Yeah.
For clinicians to use in serious illness communication, as
Yeah.
it says, right?
Yeah. Exactly. And so that's the type of intervention that's really multi-component. It partners with people like primary care physicians who are trying to engage in these skills, and it provides them with the support not only to have the discussion, but also to be reminded about how to document and when to have it, and get audit and feedback to make sure that they're doing it. So I think that that's the type of thing that we need to be looking at going forward.
My sense is we need more data about the serious illness communication guide too. We need
Absolutely.
a stronger evidence base there as well.
Yeah.
So what I'm hearing is that communication training is important.
Yes.
That also shouldn't just rely on individual modules, but like actually getting system change too.
Yeah, exactly.
But like taking a step back, do you, from your like heart of hearts, do you feel like you can teach communication, or like you either got it or you don't? Kind of like the big empathy question. Can you
Awesome.
teach empathy?
Yeah, disclosure, Eric is actually Vitaltalk faculty.
I am questioning my life right now.
No, I think it's huge, right? I mean, I think, so a lot of this is just about behavior change. And I think that that's what's different, is really looking at communication, like learning how to put it in IV, which is something that probably most of us doctors forgot how to do, but it's an analogy that works really well for nurses because they can do it, asleep with their hands tied behind their back kind of thing. And so I think that that's what's been really progressive about Vitaltalk and others who have really focused on communication skills training, is figuring out, like, thinking about adult learning and skills acquisition, and what are the basic principles that we need to effectively change what someone's doing.
Yeah, so where's the greatest need here in terms of communication skills training? Is it training interns, residents, practicing clinicians, outpatient, inpatient, ICU, nurses, social work, all the above?
All the above.
All the above?
All the above.
Yeah.
Okay, so we were actually chatting about this because we were looking at Alex's post.
Yeah.
And one of the questions that came up was, were we just targeting the wrong level of learner? Is like that they targeted interns. Like, these people are incredibly busy. They're trying to learn multiple different things. Their pagers are going off left and right, and they may be going in with some of the skill set, maybe not enough to actually go into these really deep, hard discussions, and maybe that's why they found either no outcomes or maybe increased depression.
Right, and maybe they have enough zeal to dive in, but not enough skills to actually succeed in the moment.
Sure. And you know, thinking about at an academic medical center, I mean, how, as a patient or a family, like how many people do you talk to in one day? And so it's a lot of it is just about us figuring out who is talking to this patient about what, and we're giving them about 10 million mixed messages. And you know, so I think there's a really nice article that James Tolsky and colleagues did with actually a CD-ROM intervention where they recorded people having discussions with their patients and then fed it back to them, and they found it was with their oncologist, their primary oncologist, so someone that has, you know, a really strong relationship with that patient, and they found a small but significant increase in the trust that patients had in their oncologist, as an example. So I think it is important that, you know, we're just thinking about the bigger picture of who's talking to this patient. And you know, the reason that we focused on bedside nurses in the intensive care unit is that they're really the person that's with the patient 24/7.
Yeah.
And you know, we as physicians come in and we talk for a couple minutes, but then it's the family that turns to the nurse and says, what did they just say? Or
Yeah.
so I think for each setting, it's really important to just think about who are the priorities to train, and then also minimizing communication that other people might have with patients.
And picking up on that thread, how is what you teach to nurses different from what you might teach to physicians?
Great question. I'm learning so much about that. So I think a lot of it is about us knowing more about each other's scope of practice and what we do, and that's something that we weren't trained in med school at all about, right? Is, you know, what nurses, social workers, chaplains do. Luckily, we've learned a lot about that in palliative care. And so I think that's a lot of what we need to be bringing to frontline clinicians, wherever they are, is that teamwork and how to figure out how to work together, and how as a physician to know what nurses can do and what they actually may be better at than we are, and then you know, what we need to be really taking that responsibility to do, which, you know, for physicians a lot of that is giving information, and the nurse's role is, you know, much more about the other parts of communication, which I think in palliative care we see those as probably the more important parts, right? So responding to emotion, eliciting people's perspectives, providing reinforcement for things that physicians said that families and patients maybe didn't understand.
You know, just riffing on this for a moment, my favorite depiction of nurse-led communication in serious illness is from the play Wit in the movie version.
I was actually thinking the same thing.
You're thinking the same thing? You know that scene, share it, where the nurse brings in the ice cream, and they're sharing like an ice cream popsicle, and then she sort of revisits something that the intern had sort of in a ham-handed way discussed earlier in the day, which is code status. And she does it just in such a relaxed, open manner, you know, with, you know, talking about this really serious issue, but in a way that is sort of at a very human level, and not this sort of higher level information centered, you know, academic, doctorly level.
Totally, and I think that when all of us are at the top of our game as palliative care providers, that's what we're doing too, right?
And the other thing is, I remember teaching at the nursing school in the serious illness communication, and I had a session where we talked about how to have a code status conversation. And on the flip side, the nurse's feedback to me was, we don't do this. This isn't something that we do. Sure, it was in that movie Wit, but on a routine basis, I would feel like I was overstepping my bounds if I tried to engage in this code status conversation with patients.
And where do they document it? So that's another big issue. So we have these systems of care that are not, we talk a lot about teamwork, but there's no systems of like developed for that. I would say outside of the VA. So we should probably do a whole nother podcast on what the VA is doing for around these discussions. But I think one of the coolest things is that there is a note specifically designed for nurses, physical therapists, social workers, chaplains to actually document goals of care discussions that inform life-sustaining treatment decisions.
At the VA.
At the VA.
The life-sustaining treatment.
And I don't know of any other system that has a similar kind of note.
They're working on putting one together at UCSF. I think it's live now, and I think that that's huge. And we, as physicians, need to know that we need to look at those notes. But I think that that's, you know, just getting back to this idea about scope of practice. I think that that because most of us think that goals of care discussion is about like a code status discussion, like a specific treatment, yes or no, do you want it, that's what leads leads other clinicians to say, well, oh, that's not my job, because they wouldn't be discussing a specific treatment or giving information. But when it turns out that a lot of it is eliciting your understanding and understanding what's most important to you and responding to emotions and being there in that human way, then all of these other clinicians who are touching the patients have such a huge role.
Mm-hmm. Can I ask you about role play?
Please.
What do you think about role play? Because can you simulate? Does actually simulating and role play work? That was another potential critique of what may not have worked in that 2013 study by Randy Curtis and colleagues, is that it was based on sort of role play teaching.
So people couldn't translate it into their regular life.
Right. What do you think about role play?
Great question. I know that I've had some really challenging experiences around role play in medical school, and it was one of the hardest things that I did there. And so I think that the advice that I would give about role play is, if you're going to do it, get the training to really understand what you're doing and understand what's important. And so we think about that role play has to be learner centered. It has to be about what you want to do. It has to be a really safe space. It has to be focusing on what you already know that you do well. But I think the important thing is that, just like learning any other skill, there's no way that you're going to learn how to do it unless you actually say the words. Mm-hmm. And I think that's the other thing that we're working on in communication skills training, is figuring out, once you've gained some of those skills in a workshop setting, how do you then take that back to the bedside? And so thinking about how, when we're supervising fellows, how can we be making that actual communication into a training session? A lot of what we've been working on with IMPACT-ICU and with Vitaltalk is thinking about how palliative care specialists, whatever clinician they are, can be coaches for people to better provide generalist or primary palliative care.
Can you say more what you mean about coach?
Sure.
What is a coach?
Yeah, so a coach is someone that you go to when you feel like you're not really sure what to do. So Massachusetts General Hospital has this great peer coaching consult program, and there's a really neat study that was done out of University of Wisconsin in their ICU, where the palliative care team went to ICU rounds daily, but they didn't actually talk to any of the patients. And again, this was a small study, so need to replicate it and all of that, but they found that just by talking to the ICU team on a daily basis about high-risk patients, there were more family meetings. The ICU length of stay decreased for patients who died, but not those who didn't. And they actually saw a trend towards lower PTSD symptoms in family members. So I think it's really interesting for us to, given the shortage in the palliative care workforce, to be reconceptualizing our role as palliative care clinicians to how do we kind of extend our reach, and so that we can be coaching the folks who are on the front lines, who may be the ones who already have that relationship developed with a family and patient.
Is there more to coaching than, say, what we would do ordinarily as like palliative care supervising attending? I mean, it's not like you do a timeout in the middle of a session with a patient and family and say, let me give you some advice here. We need to pull you to the sideline, and we're going to huddle, and then you're going to go back in the game.
Right.
It's all sort of after the fact feedback for the most part.
Yeah. Or am I doing my in Little League Baseball, keep your eye on the ball.
Well, no,
vague statements that actually just mainly scare the kid.
So the
swing at anything, but keep your eye on the ball. Don't swing at those.
But see, first you just said one thing that they were working on, right? So I think probably my favorite book that I read recently about just teaching in general was Practice Perfect from the Teach Like a Champion group, and Bob Arnold said, read this and then you'll understand why we do all this stuff. And I was like, oh, I understand why we do all this stuff now. But I mean, they use tons of sports analogies, right? So they talk about which basketball teams are just amazing, and what their coach has done is that they do a lot of drills. So they do a lot of preparing people to go into the situation, even down to tying their shoes. And then they do that over and over again, and that's the Practice Perfect piece, is make sure that you're doing it right and that we know you can do it right. So that's the role play, is you have a facilitator making sure you do it right. But then when you go into a game, you know, likely that's a totally different situation. But the practice for, you know, for a fellow might just be, like, we ask them what they're worried about, we give them one skill that we know that they can do before they go in, and then we take notes about, you know, like, what was one thing that went well and what's one thing that they could work on for next time.
Let's say we have a Jerry Pal podcast listener in Lexington, Kentucky.
For example.
Another one in Mobile, Alabama.
Yeah.
And they want to learn how to communicate in setting of serious illness,
Yeah.
and maybe even take the next step of being a teacher
Sure.
of how to do this.
Yeah.
What sort of resources are there for this person?
Walk us
these
through
people?
the steps.
Yeah, awesome. So there's one of the things I really like about Vitaltalk is that there's a lot of nice online videos and apps and resources that you can access. So there is a app called Vitaltalk Tips, which is free, that you can download, and it talks, including evidence, about all the different types of conversations that you can have around a serious illness, and gives you tips about those so that you can use those in the moment. There's also a lot of really nice videos that are online at Vitaltalk, so that you can actually use those as models and see how that works. They have a really nice online training program that incorporates some of these aspects that we talked about for learning that you can take online. And then there's also in-person courses, both an initial 8-hour course which focuses on teaching you yourself how to lead these discussions, and then there's also a faculty development program after that.
Great.
And for IMPACT-ICU, we actually have a lot of resources that are free and online there, and there's a series of webinars that we developed with the American Association of Critical Care Nurses that are also interactive and use some of these same principles.
And to get the impact,
it's on the Vitaltalk website under resources, or you can also look at AACN, American Association of Critical Care Nurses, and Google Palliative Care, and you'll see within their website.
and we'll put all those links on our Jerry Pal blog that's
Yeah.
associated with this podcast.
And YouTube video.
And YouTube video.
YouTube.
Oh no.
Low battery.
Well, that's not good.
It's not out yet.
Oh, it's
We're
still
still here.
recording.
Oh good. Okay.
This is
Let's see
our
if this
first
works.
YouTube video,
Yeah.
so, well, yeah, and maybe our last YouTube
Maybe.
With the
video.
headset.
We'll see. Is there anything else that we should be talking about right now that you think is really critical around communication and teaching?
Yeah, I think that a big piece is just us thinking about, not only training interprofessional teams, but also thinking about tailoring. Really communication is one of the main interventions that we do in palliative care, right? And it's probably the thing that makes the biggest difference to patients and families. I think there would be data to support that. And so I think we really need to think clearly, like all other things within palliative care, about how do we tailor this to different populations, that a patient who has just had a huge, motorcycle trauma and is in the trauma ICU, their palliative care needs are totally different than a patient who is frail and elderly, or a patient who has metastatic cancer. And so we just need to partner really closely with people who are working with those patients and who know all about those patients. And I think that's also true for, the diverse populations culturally that we care for in California and across the country. And I think that those are a lot of the things that we're working on in the Bay Area Hub, is thinking about, well, how do you navigate, talking with a family whose decision-making process is totally different from Western ethics, and how do you, still feel like you're consistent with those Western ethics, but while keeping it patient-centered and family-focused.
Yeah, that's great. Yeah. Terrific, given the rich diversity of the Bay Area and the growing diversity of our country. These are such important issues. How do you respect autonomy when it's not a patient-centered decision? It's
Right.
a family-centered decision.
Right.
Yeah, it's great. Anything else?
That's my main thing.
Well, I learned a ton. What was the name? The name of the book. I always want to say
Practice
yeah.
Perfect?
Pitch Perfect.
I
But
think
that's
that was
a
a
movie.
movie.
With
Which
Anna
is
Kendrick,
also
different.
which was
very
awesome.
worth watching.
Is that the one
Then
with
you
the
might
cups?
like the sentence too.
Right. Cup song? that
The
one?
cup song.
Yeah,
Yeah.
yeah.
So maybe we'll have you do that next.
No.
For next podcast.
Long way round.
Maybe you could just end a little bit with some Descendants. When you
Oh,
said
right.
Descendants, I
The reason-
initially thought about the George Clooney Hawaii
Oh, that's what I thought. I was
Descendants.
gonna
Yeah,
play a
no,
little
that's-
slacky guitar.
That's
Ukulele.
way, that's way highbrow. I thought of my other thing.
Yeah, what's your other thing?
So there's this article that I really love about that Atul Gawande wrote that's about slow change, and so I think that's so much we get so frustrated by like everything's wrong and our health system is so messed up, and so I think that this article is all about, it's called Slow Ideas, and it's all about basically healthcare change and things that haven't caught on quickly. That it's all about individual relationships. And so, our individual relationship as a palliative care specialist with someone who we're coaching and teaching communication skills, or our individual relationship with a patient or a family.
That's great.
Slow change.
Slow change. And change. It's in the song. You gotta be bold, you gotta be brave, you gotta be free. You gotta get loud, making that change, you gotta believe. We'll look deep inside, and we'll rise up and shine. We can be bold, we can be brave, let everyone see. Starts with you and me, whoa, whoa, hey, hey. Starts with you and me, whoa, hey, hey. It starts with you and me.
Nice. Well, Wendy, big thank you for joining
Thank you, Wendy.
our very first YouTube video too, and thank you to all the listeners. We look forward to having you on our next podcast next week. And one more favor, if you're listening, if you haven't rated us on your favorite subscription service, whether it be iTunes or any other podcasting service, or on YouTube, take a moment and give us a rating.
Bye, folks.
Bye.